Hello and welcome back to our third part on neuroperfusion scanning. In this video, we will be going over the specifics of scanning neuroperfusion and how to optimize our scans. So today we're going to go over a few different things in this lesson. So the first is to describe the key elements of CT Neuroperfusion Imaging protocols. Next, we will demonstrate patient positioning techniques for CT Neuroperfusion Imaging, including proper alignment of the head and neck to optimize image quality and minimize artifacts. And finally, we'll explain the setup of a CT scanner for neuroperfusion imaging, including selection of appropriate scan parameters and contrast injection protocols to ensure accurate and reliable perfusion data acquisition. So perfusion is no different to any other CT scan in the fact that at the start of it, we're going to start with a topogram. So for our perfusions, we always do an AP and lateral topogram. And since we're going to be doing our head and neck angiogram, we need to include we've got from the vertex all the way down to the aortic arch. This is also a good step for us to ensure that we've got our patient positioned correctly with that chin tucked and our base of skull aligned. So our first step in our stroke protocol is to scan our non-contrast head. So the main point of the non-con head is to decide if the stroke event is ischemic or hemorrhagic. This is because the treatment methods for the two are vastly different. In an ischemic stroke, we can give blood thinning agents. We may be able to increase blood flow to the at-risk tissue and therefore save some of it. On the other hand, if we give blood thinning agents to a hemorrhagic stroke, we will definitely worsen the patient's condition, which we don't want to do. As well as this, the initial non-con gives the clinician a good idea of if there are any established areas of infarct or any long-standing ischemic changes. On our non-con head, we sometimes get a sign called the dense vessel sign, which we can see just in here. So the dense vessel sign is suggestive of an acute thrombus in a cerebral artery, often indicating acute ischemic stroke, and these are most commonly seen in the middle cerebral artery. For this scan, we're just going to use standard brain exposure factors and algorithms that are set up for all of our other CT heads, so nothing special for this one. So the next step in our scanning is our CT head and neck angiogram. So on this scan, the main thing our radiologists and interventionalists are looking at is assessing the vessels to locate the clot. So when they're doing this, they're determining the chance of them removing the clot. So if the clot is too distal, in a tiny vessel deep within the brain, it can be hard to get to, and they might not be able to remove it. And that's when we look at going down medication routes, so thrombolytics or blood thinning agents to manage the stroke that way. As well as this, they're looking at any risks that they may encounter during the ECR. So for example, if there's clot in the carotid artery that they might knock and therefore increase the clot burden in the brain, they obviously don't want to do that. So the scan can be performed after the perfusion as well. If we do this, we wait 5 minutes post-perfusion, and that's just so that that contrast has time to drain away, so we get less venous contamination in our brain. And our scan range will be from the aortic arch to above the vertex to incorporate all of the head and neck vessels. So for our head and neck angiograms, so we inject at 5 mils a second at least. We can go faster in bigger patients. And we're going to inject, again, at least 50 mils of Omnipaque 350 or similar, followed by a saline flush of 50 mils. Okay, so let's get into the nitty-gritty of our perfusion scanning. So if we think of a normal CT as a photograph, we want to take a still image at a particular point in time. A perfusion scan is more like a movie. We want to track the blood flow through our brain over time. So to do this, the scanner does a series of low-dose scans. And as we spoke about in the last video, we're limited to how much we can scan on our Siemens scanner. So we're limited to an 11.4 centimeter scan range using job mode, because the patient moves back and forwards throughout the scanner over these time points. So our first scan is done after a 5-second delay. This is to aim to get a non-contrast baseline. So 3 seconds after this, the main scan starts, and this is trying to capture our arterial input. So every 1.5 seconds, it will move the patient back and forwards and start a new scan. So after this main scan, it does another scan 4.5 seconds, and this is just to ensure that it has captured the venous drainage so that we can get accurate graphs for our perfusion mapping. So as I just mentioned, the main aim of our perfusion scan is to visualize the contrast flow through the brain captured over time. And to achieve this, the scanner moves the patient back and forward through the gantry, and this is why our scan range is limited. So the goal of the perfusion is to decide if there is or isn't a stroke, where the stroke is, what vessel is occluded, and if there is ischemic core, being the already dead brain tissue, or any penumbra, which is the salvageable tissue. So obviously our aim is to have a minimal core and a large penumbra, which means when we remove the clot, there's a chance that that brain tissue will still be salvageable. So the perfusion can also determine if there is collateralization of that area and display this. So what we mean by that is that the main artery might not be giving flow anymore, but there's still other arteries that are giving flow to that brain tissue. So that increases again the chances of us being able to save that tissue. So perfusion maps are created, and they're similar to what I've displayed here on the side. So they show cerebral blood flow, cerebral blood volume, time max, and a delay time. So cerebral blood flow, which we can see here, it indicates how much blood flow is getting to the area. So if there is no or minimal delayed flow to that area, this tissue will be at risk. We then correlate to our cerebral blood volume, which indicates the volume of blood remaining in that area of tissue. So if we have reduced flow, yet our tissue still has a good blood volume, if we restore that flow quickly, the brain can heal. If our flow is low and our volume is low, that brain tissue unfortunately is already too far gone. So all of these maps are calculated relatively to the contralateral hemisphere. So it's not going against a baseline that we've said everybody's brain should be at. We're comparing that patient to that patient. So in part 4 of this video series, we'll go into more detail of what these maps mean and how they're actually calculated. This is just a little glimpse of what you'll see. So next, we're going to look at the scan range that we want to set up for our perfusion scanning. So the reason this is particularly important is because we've got a limited scan range, as I've mentioned quite a few times. So research on CT perfusion into the assessment of the cerebellum isn't readily available, although most perfusion research states that it is of little significance. Now, this is mainly due to artifact from adjacent structures, such as the base of skull, limiting its usefulness. However, there's another reason that we don't need to include it. So, due to the importance of the brainstem in critical functions such as breathing, if we see a posterior circulation stroke, we're going to go and retrieve that clot. So, cerebellar infarct quantification is not quite as important, and therefore for our CT perfusion, we really want to include as much of the supratentorial brain as possible. So that's imperative to ensuring that we can capture the most amount of brain that's actually useful for a CT perfusion. If we do want cerebellar infarct quantification, MRI is still our gold standard. Obviously, our skull is also not going to uptake contrast, so therefore we don't need to include that. So we want to ensure that we're just above that base of skull and we've got as much of our brain as possible. So by doing that chin tuck, we can ensure we still include that cerebellum so that we can see if there is any posterior circulation infarct. But if our head is tilted back a little bit, don't worry too much about cutting off some of that cerebellum and start just above the base of skull again to include our cow and as much as the brain as possible. So this was a perfusion performed within our department. I've taken it, just done a quick sagittal image from it, just to show you some areas where we can improve. So this patient was positioned correctly, so that base of skull is beautifully in plane. We've just started our scan a little bit too low. So we've got a centimetre of bone covered here. So that centimetre would have been far more beneficial at the top of our scan in the actual brain tissue. As I mentioned earlier, the bone isn't going to be uptaking any contrast, it's not going to be a stroked area, we really don't need to include it in our perfusion. As well as that, due to the low dose nature of the scan, it's not going to give us any benefit in assessing the arteries, the input into the cow. So we can just bring our scan range up a little bit. This sagittal image also shows us nicely that artifact that we get due to like the orbital roof and the petrous ridge through our brain. And it just shows us why that cerebral infarct is so hard to quantify. But also, again, just lets us know we can increase that height of our scan range a little bit. So you're never going to be too low. It's always good as long as you've got your cow on and as much of the top of the brain, the supratentorial brain, as possible. So next, let's look at our contrast protocol for our perfusion scanning. We go pretty quick in our injection on our perfusion scannings. So due to that, we actually need an 18 gauge cannula, and normally in the ACF, and that's required for all perfusion imaging. So if the patient doesn't have an 18 gauge cannula, we can't actually perform our perfusion scans. So we inject at 7 ml per second, and we inject 50 ml of Omnipaque 350, followed by a 50 ml saline flush. So the reason we need that 18 gauge, so 20 gauges are limited to 6 mils a second, so we're going faster than what a 20 gauge can actually handle. So that's the most important thing before we get a patient on the table for a stroke call, is just ensure that they have that cannula in. Okay, this should be a pretty easy one since we just went through it, but what is the desired flow rate for perfusion scanning on the Siemens system? Okay, so the answer to that one, 7 mils per second. Okay, so our next question then is what cannula is the minimum size required before we start our perfusion scanning? So a bit of a trick question here. So we asked for the minimum size for perfusion scanning. So the minimum size is an 18 gauge. We can't inject through a 20 gauge. But considering a 16 gauge is bigger than an 18 gauge, we can actually use that. So although we can use a 16 gauge and an 18 gauge, the minimum size required is an 18 gauge. Okay, so what are our key takeaway messages from this video? So there's 3 parts to our stroke perfusion protocol. So our non-contrast head, our head and neck angiogram, and then finally our perfusion scan. The important thing during our perfusion scan is to make sure we're scanning the maximum useful brain. So do not include the base of skull on your perfusion images. If we do that, we'll be hunky-dory. Thank you all. I hope you all learnt something from that video, and I'll see you all in the next one.